rest is the worst possible strategy to chronic or even intermittent low back pain. Rest is the most insidious pain management strategy because long term, as you play this out, you rest, you get tighter, you get weaker, you restrict your lifestyle, and then you go about your life in a weaker and tighter and more unstable state. And then the next time it hurts, you do less and you get tighter and you get weaker. And so it's this retreating strategy of backing yourself into a prison inside of your own body that can't do the things that you love, that can't walk out to the mailbox. I mean, it's really a self-defeating strategy long term. Rest is the most insidious of the pain management strategies. Welcome to the Joint Pain Podcast, where we have discussions on the science and art of joint pain and longevity. I'm your host, Matthew Lister, the founder of Align Pain Management. Today, I am talking with Jake Gibbins. Jake achieved his bachelor's degree in kinesiology from Oregon State University and a master's degree in the science of human movement from Concordia University. He is an NSCA certified strength and conditioning specialist and did post-acute rehabilitation for athletes. He now works to lead people out of pain and teach people how to steward their joints well as a joint pain coach at Align. Thanks for joining me today.
Thank you, Matthew. Thank you for having me. It's an honor.
Okay, so I'd love to just build a little bit of context around who you are and why you do this work before we dive in. Why did you choose this for your life's work, or you spend your energy on?
Great question. It all starts back in high school. I wanted to be, a college star. That was my goal, play ball, college. I got hurt senior year of track, did PT, all that, tried to go into spring ball, ended up tearing my hamstring, and it was over. So I left sports, and then I found out after working for a while, I want to be back in helping people achieve their goals because, unfortunately mine were cut short. So.
Yep. So you've experienced injury, you've experienced pain and the rehab process.
Absolutely.
And it's all of its messy pros and cons.
Yeah, definitely.
Awesome. So you moved from doing post-acute rehab work on athletes to helping lead people out of chronic pain. Yeah. Does that feel like a big shift? I know scientifically it's a big shift. Does that feel like a big shift?
Yeah, scientifically, yes. Awfully different body types, but in a way, no, because when athletes get injured, they go down the same thought, same pattern as people in chronic pain. They have, when you're in a bad place of, I possibly can't play anymore, maybe my career is over, all that, it's an issue. And that's one that you got to try to build them up, just like people in chronic pain. Once you get them better, they forget all that. But those couple months when they first start, it's a struggle for them.
Totally. Yeah. When people are in chronic pain, there's that fear that I'm never going to be able to do the things that I love again. And am I going to be like this forever? And that is the same for athletes as for everyday people with chronic and intermittent pain. So yeah, I can see that. So today we're going to be talking about how to fix low back pain. Today, I want you playing the role of the simplifier. I want you asking questions and forcing us to simplify some of these more complex words and concepts.
Okay.
Sound good?
Sounds great.
So on today's podcast, we're going to have two sections. The first section is going to be the simple takeaway. This is going to be a high-level overview with a 7-point checklist for fixing your low back pain. And then the second part of this is going to be a deep dive where we're going into each of the individual components and really doing a deep dive on the concepts for those people who want to really dive in and understand some of these concepts at a deeper level.
Okay.
Let's dive in. How to fix low back pain. Let's start with the simple takeaway. 90% of low back pain cases are classified as non-specific low back pain, which means it isn't possible to identify a specific disease or structural reason to explain the pain. The implications of that are huge. That means that 557 million people worldwide are left with intermittent or constant low back pain, and they aren't given a clear reason why, and they don't have to be in pain.
Wow, that's a lot. That's something to highlight, 90% right there.
Yeah. The second point, research has shown that low back pain has more variables than any other joint pain area. On average, there are 15 to 30 individual contributing problems that add up to creating people's pain. The third thing, there is a low back equation, okay? And we've created a 7-point checklist to fixing your low back pain. So we're going to cover that. The low back pain equation is joint problems plus stress problems equals your pain. So the first part of that equation, joint problems, includes pelvis and core instability. The second part is structural issues. The second part of that equation, stress problems, includes inflammation problems and nervous system problems. So pelvis and core instability, structural issues, inflammation problems, and nervous system problems all add up to your pain experience. Next, I want to go through the 7-point checklist to fixing your low back pain. So this is 7 questions that if you can answer yes to all of them, you will fix your low back pain. Super crucial. This is a really good takeaway for people. So joint problems. Let's talk pelvis and core instability. 3 key questions. Number 1, are my glute medius muscles strong enough? And we'll cover what that means and what those standards are in the deep dive if people want to go find that. Second question, are my hip flexors and abs strong enough? Third question, is my low back, glute max, aka my butt muscles, and hamstrings strong enough? That's under pelvis and core instability. Structural issues, 1 key question. Has a world-class surgeon confirmed I don't need surgery at this time? Got to be able to answer yes to that. Second part of the equation, stress problems. Inflammation problems, there's 2 key questions. Have I eliminated ultra-processed foods? And secondly, am I doing 3 30-minute sessions of low-intensity aerobic training per week? Nervous system problems. 1 key question. Do I have anxiety, depression, and sleep well regulated? 7-point checklist. If you can answer yes to those, you will fix your low back pain. The last part of the simple takeaway is just a message of hope. You don't have to be in pain. Solutions exist. It is complex, but there is a way out. That is the simple takeaway for the episode.
Absolutely.
All right, let's go into the deep dive. So scope and statistics of our talk. Point 1, low back pain is the most common musculoskeletal condition and the leading cause of disability globally, with 619 million people affected. A lot of people.
A lot of people.
Is the most common joint pain area.
And why is it the most common?
Because it is complex and so many things pour into that area. I mean, it's just rife for compensation, for emotional and stress and inflammatory. It's like the American lifestyle and American culture has been designed to create low back pain. Everything from the height of our stairs to our jobs being based around sitting. I mean, there's just so many variables that all are just perfectly designed to create low back pain. Yeah. Specific low back pain is low back pain caused by a specific disease or structural issue in the spine. Specific low back pain makes up only 10% of low back pain cases, which leaves 90% of low back pain cases as non-specific low back pain, which means there isn't a clear known disease, cause, or structural issue that can be pointed to. And people are just left with this sort of shrug by their doctor going, we don't really know what's causing your pain. And they're just left carrying that. They're left carrying the pain, the confusion, the fear. And I mean, I think the implications of that are huge.
Absolutely. Absolutely. And only 10%. That's crazy.
Yeah.
Is that 10% visually structural that they're finding, and that stuff that they're setting aside and saying, okay, we can definitely look at this and see this as an issue?
Yeah, that 10% of specific low back pain cases are, you can see the structural issue on the MRI, and there is a clear cause for why this person is in pain. Severe stenosis, a big bulging disc, severe arthritis, something that is really glaring on an MRI that you can point to and go, yep, that's causing your pain with a high degree of certainty. Everybody else gets the shrug.
Yeah. And then what would be the next step for that shrug for a client?
Man, it's not great. A lot of times it's pharmaceuticals, it's pharmacology, it's some real unfocused physical therapy at times. Other times people will go through physical therapy multiple rounds. It kind of helps, not really. They'll go to a surgeon. The surgeon kind of shrugs and goes, well, we could do the surgery, but it's sort of a coin flip of whether it's going to help you or not. And nobody really wants to take those odds. And so they're just left in this place with no clear answers, no clear sense of direction or leadership as to how to get out of pain. And they're flooded with opinions from their friends and their family and, should I rest? Should I exercise? I know I'm too weak. And so they just get flooded with opinions and perspectives on all the different things that are causing their pain. And it's just confusion. That's really the state that characterizes that non-specific low back pain is just confusion.
It's unfortunate.
Yeah. So the next part of the deep dive is how you interpret and respond to pain really matters. So you experience back pain. Yeah. How should you respond? You have two bad options and only one good option. So we're going to unpack that. Let's start with the two bad options. So the first is rest and lifestyle restriction. So you experience pain. What do? Rest and lifestyle restriction is the first bad option. Rest is the worst possible strategy to chronic or even intermittent low back pain. Rest is the most insidious pain management strategy because long-term, as you play this out, you rest, you get tighter, you get weaker, you restrict your lifestyle, and then you go about your life in a weaker and tighter and more unstable state. And then the next time it hurts, you do less and you get tighter and you get weaker. And so it's this retreating strategy of backing yourself into a prison inside of your own body that can't do the things that you love, that can't walk out to the mailbox. I mean, it's really a self-defeating strategy long term. Rest is the most insidious of the pain management strategies.
Absolutely. I imagine most times when you do injure yourself, the main thing you want to do is rest. You just want to sit there.
It's a very natural feeling strategy.
Yeah.
But it is so dangerous. The second worst response to pain is ignore and override. And this is typically people who have pain, but they have a job to do, they have a family, and they just go, I don't have time to be in pain. I'm just going to keep going. And again, that feels very natural, especially for people who pride themselves on being mentally tough and having a high pain threshold, all of these things that are theoretically good. The problem with that is that pain is a signal telling you that there is something wrong, often biomechanically. Something isn't working right. And when you ignore that pain signal and override it and keep going, you allow biomechanical problems to exist in your body for long periods of time without getting fixed. And that just leads to bigger and bigger biomechanical problems. It leads to knee replacements. It leads to back surgeries. It leads to more structural damage because you've allowed instabilities to exist for longer periods of time.
Absolutely. I think one thing would be great to clarify for the viewers is you're overriding the problem and then it goes away. Do you still need to do something about that? Is a problem still there? It's just masked now by different treatments?
Yeah, no, that's a great question. So that the pain, so you override that pain signal, you keep living life, and the pain goes away. So must be okay. The problem must have went away. Not the case. The problem, it just went sub-symptomatic. It went sub-pain level. And so your body just stopped interpreting it as a major threat. It stopped sending inflammatory mediators to the area. So it more than the problem went away, your immune system and your nervous system stopped responding to it as a major threat.
Okay.
The problem persists.
Still there.
It's still there. The one good response. So out of the 3 possible responses, here's the one good one. This is a key takeaway for people. The one good response is explore and correct. So let's first understand what pain signals are. Pain signals are the check engine light of the body. When your check engine light comes on in your car, what do? You take it to the mechanic to figure out what's wrong. You don't put a piece of tape over the check engine light. You don't like take a hammer and try to like smash the check engine light so it goes off. You don't like go in the back and unplug the check engine light. You go, okay, there's something wrong in my car, and my car is telling me that, and so I need to take it to an expert to get it evaluated so I can see what the problem is. And if I leave that check engine light on longer, my problem is just going to get worse and worse and worse. And so the best way to understand pain is understanding it as a check engine light. Your body is just trying to tell you that there is a problem. And so the best way to deal with that is to look at that with a curiosity and recognize what it's trying to tell you. It's trying to tell me that there is a problem. I need to correct that problem. You can either try to DIY that, or you can take it to an expert to identify what that problem is. But the one good response to pain is explore and correct for that pain signal.
Absolutely. And you mentioned DIY. That's information is everywhere.
Yep.
And you can get it so easily from everyone, but the way that you've been able to channel it all and make it simple for clients has been tremendous. You make it step-by-step process, goals we have to achieve to get there.
Yeah. I never want to discourage people from trying to DIY their pain problems. The stark reality is that these problems are highly complex, and there is a whole study and language of biomechanics and movement and understanding how your body is supposed to work, and most people just don't have a grid for understanding how their body is supposed to work. And so I never try to persuade people away from a DIY strategy, but the chances of success are considerably lower. My recommendation is evolving to just getting an annual well care check on your joints. And so just going into an expert and head to toe, getting your joints evaluated for small or large biomechanical problems. If you can find those problems earlier, when they're smaller problems, they're easier to fix. You can get education about those problems. When you wait until you're in your 50s, 60s, 70s, and you have this big mess with a lot of different really entrenched problems, it's just so much harder to fix. It can be fixed, but it's just harder to fix.
Absolutely.
The next part of this deep dive is something we touched on earlier in the simple takeaway, but it's complexity. It's the complexity of low back pain. Low back pain is in the top 3 of the most multifactorial joint pain areas. Some joint pain areas like the feet and your knee or your sort of outside of your thigh, your IT band, if you have IT band syndrome on the outside of your thigh, those are all significantly less multifactorial. There's less factors that go into them. You can list them on one hand, 3, 4, 5 things. Low back pain is a beast. There are 15, 20, 30 different variables that all stack up on top of each other to create people's low back pain experience. And it's it's so complex and it's so confusing. And you go to one expert and they deal with one of the 20 problems that you have. And then you go to the next expert and they deal with one of the 20 problems, and you end up with 20 differing opinions. And nobody's saying the same thing. Nobody can agree on what your problem is. Well, they're all right. They're just all looking through the keyhole of their specialty. And the reality is that there are 20 different problems stacking up to create your experience of pain. And in order to get out of pain, you can't deal with one or two. You have to deal with all 20 of them. Let's dive into simplifying that complexity. And so one of the ways that we help people understand low back pain is with the low back pain equation. So we've simplified it down into what we call the low back pain equation, which is joint problems plus stress problems equals your pain. So the first part of that, which is joint problems, consists of pelvis and core instability and structural issues. The second part of that equation, stress problems, which includes inflammation problems and nervous system problems. So when you add up pelvis and core instability, structural issues, inflammation issues, and nervous system issues, you get your pain experience.
And how does someone determine where they're at and which one is causing their pain?
Yeah, that's the hard part, and that's the illusion, right? It's not just one that's causing their pain. It's not two, it's 5, it's 10, it's 15, it's 20. And which one or which 5 are the bulk of the problem versus which 3, 4, 5 problems are just amplifiers of the problem, amplifying the pain. Yeah. That's where science becomes art. And in this deep dive, we're going to talk about optimal treatment order, what you should do first, what you should do second, and we're going to break these down and talk about what are the standards. So how can you identify if you have pelvis and core instability, and how can you identify if you have inflammation problems? So we'll dig into that, and then we'll talk through optimal treatment orders. So let's unpack each variable in the low back pain equation. The first part of the equation is joint problems, which includes pelvis and core instability and structural issues. Let's break down pelvis and core instability. We're going to start with an analogy. Your spine is like a stone column resting upon the foundation of your pelvis. The state of that stone column is dependent upon the stability of the foundation that it is resting upon. If your pelvis is really stable, when you walk, it stays nice and level. It's not doing a lot of this. It's not sinking. It's not shaking. That stone column resting upon that foundation will last for centuries. If that foundation is unstable, if you build your stone column on sand instead of rock, that column is not going to last long. If your pelvis, that foundation is collapsing when you walk, it's rotating, it's unstable, you're just going to create an unstable foundation for that stone column, and it's going to crack and it's going to collapse, and you're going to have all these structural issues that are so rampant in our culture. So the first part of pelvis and core instability is glute medius weakness. Okay, so your glute medius muscle is your glute muscle, but it is the glute muscle on the side of your hip, not your big butt muscle, your glute max. So it's the glute medius muscle on the side of your hip, and it is responsible for stabilizing your pelvis during your gait, during your walking cycle, when you're sitting down and standing up, when you're going upstairs. So it is really the prime stabilizer of your pelvis when you're on one leg. So it's really crucial to have it really strong. So a standard for stability. How do I know if mine is strong enough? We'll link a video to this, but basically you should be able to do an outer thigh raise for 3 sets of 30 reps with a 5-pound ankle weight. If you cannot do 3 sets of 30 with a 5-pound ankle weight with good mechanics, your glute medius is not strong enough. A sort of a real world way of assessing is when you're walking, do you sway side to side? When you're walking, does your pelvis collapse? Is your pelvis doing this when you walk? When you stand on one leg, do you sway to the side more than an inch? When you sit down and stand up, do your knees collapse in an inch? Because that glute medius is responsible for stabilization. And so when you go on one leg, when you sit and when you stand, if you see those signs of instability, you know there's a problem there.
Okay. And can you clarify, is this the same for both sides, or is one side different than the other when it comes to the glute medius?
Yeah, you want to have symmetrical strength. Stability is all about symmetry, side to side, front and back. That's what stability is all about. Okay. So how to fix it? Outer thigh raises. It's part of the test.
Yes.
And so outer thigh raises are an exercise where you lay on your side and you lock out your knee. Your legs are straight. You lock out your knee. You flex your ankle. You keep your leg slightly behind your center line, and you raise your leg up. Again, we'll link a video because this isn't a great format for sort of an exercise demonstration. Yeah. So we'll link a video to that movement, but you should be able to do that raising your leg while you're laying on your side with a 5-pound ankle weight on your ankle. And you should be able to raise it and lower it for 3 sets of 30. Moving on. The second part of pelvis and core instability is hip flexor and ab weakness. Why does it matter? Your hip flexors and your abs, the muscles on the front side of your torso, are part of the triangle that stabilizes your low back and your pelvis. And so without strong hip flexors and abs, you can't have a stable spine. You can't have a stable pelvis. And so having very strong, or at least adequately strong, hip flexors and abs are just critical to stabilizing the pelvis and the low back.
So when these muscles feel tight for clients, are they still weak?
Great question. Yeah. So part of the hip flexors is the psoas muscle. The psoas muscle, seemingly, especially in, I would say, the massage therapy world, is sort of the root of all evil. It's everybody's is tight, and you may or may not have a tight hip flexor, but typically when muscles are tight, it's for a couple of reasons. One is because it's tight because it's doing the job for a different weak muscle. And so it's compensating for weakness elsewhere in the body. But secondly, things can be tight because they're weak. It's just a protective mechanism. And so the solution to tight hip flexors is very often just strengthening them. And if you're not sure if you have tight or if it's loose, just start strengthening, because it'll loosen up as you do the exercises to strengthen it. You just want to strengthen those hip flexors through full range of motion so you can make that muscle strong and long. That's really what muscles need to be.
Got it.
Standard for stability. So there's a couple here. Your hip flexors are the muscle that raises your leg. When you pull your knee up, that's what your hip flexors are doing. And so our standard for hip flexor strength and TVA strength is first and foremost the front leg raise. And so lying on your back, leg out straight, and you were just raising and lowering that straight leg up to about a 45-degree angle. And again, 3 sets of 30, 5-pound ankle weight minimum. And so how do you How do you get to that standard?
Yeah.
Start doing front leg raises.
Now, should someone start with 5 pounds right away?
Good question. That's why we have you here, because you have all the good questions, Jake. No, start body weight. You may even need to start with a bent knee in order to make it even easier.
Okay.
People are often shocked at how weak their hip flexors are. And so start body weight. And if you can't get 10, 15 front leg raises, again, we'll put a link in the show notes to that video, to that exercise video. If you can't get 10 reps with body weight, go to the simpler exercise with just a bent knee and just raising that leg with a bent knee. That'll make it substantially easier. But if you can get 20, 30 reps, build up your reps to where you can get 30 body weight, and then add that ankle weight. Maybe it's a 1 pound ankle weight or a 3 pound ankle weight. Don't go from body weight to a 5 pound ankle weight. Go to a 1 or a 3 pound ankle weight and build up to 30 reps, and then go up to the 5 pound ankle weight, and you might get 10 reps, 15 reps, and then just build up 20, 25, 30 over time. And that 3 sets of 30 with the 5 pound ankle weight is really the standard for stability.
Okay.
I would say there's a secondary standard for stability for hip flexor and abs, and that's just a basic plank, right? And so everybody should be able to do a 1, 2, 3 minute plank, and if you can't, you have weakness through hip flexors and TVA. The third part of pelvis and core instability is posterior chain weakness. What does that mean? It's just the muscles on the back side of the body. Low back, your butt muscles, that glute max, and your hamstrings, the muscles on the back side of the thighs. That is the back part of that triangle, right, that stabilizes the pelvis and the low back. So abs, hip flexors are the front side. The posterior muscles, the muscles on the back side of the body, are the back side of the triangle. And then glute medius, pelvic floor is the bottom side of that triangle. Again, why does that matter? Most of our day-to-day activities are walking, forward stepping, getting in and out of a chair. They're forward propulsion movements. Well, the muscles on the back side of the body, the low back, your butt muscles, the glutes, your hamstrings, those are the muscles that are doing the forward propulsion. The glute medius muscles on the side of your hips are doing the stability for that forward propulsion, but the muscles on the back side of your body are doing that work. And so if the muscles on the back side of the body, the low back, the glutes, the hamstrings, are too weak to stand up to the rigors of your lifestyle, you're going to have problems. And so you just have to have adequate strength through those muscles.
Okay. Is there strength metrics for the posterior chain?
So as a standard for stability, as a minimum standard for stability, you really should be able to do a 2-minute static hip bridge. Okay. We set significantly higher standards for our clients because they're under our oversight, right? We will regularly want, as you well know, we will regularly want our clients to be able to hip bridge their body weight or deadlift 100 to 150 pounds, which is, again, a posterior chain exercise. But as a minimum standard for stability that requires no equipment, a 2-minute static hip bridge is a baseline.
Okay.
And again, how to fix? Just start doing that static hip bridge. And again, we'll link that exercise video in the show notes so that way people can watch that and learn how to do that properly. And again, how to fix? You just get started doing it. 2, 3, 4 days a week. Get down and start hitting these hip and core stability exercises.
Is there any exercises that you would recommend clients do before they start all of them? Is there a certain standard or metric that you like to see first?
Yeah. So when people are working with us at Align, we get to operate in an ideal environment where people are being led by experts. And so we have a whole bunch of metrics that can really optimize the speed at which people can progress through these stability exercises. And so we first start with calming the nervous system for a few days. So that way we can reduce the amount of stretch reflex, the amount of resistance to stretch that muscles will give. Then we fix the mobility problems that we find in the biomechanical systems. And so we fix all the joint range of motion problems before we start working on the stability problems. That just allows us to get access to those small stabilizing muscles that can be really hard to get firing, that feel like they're just not even there because your brain has forgotten how to fire them. And so once we fix the range of motion problems, then we start working on these stability muscles and these stability problems that we find in the biomechanical system. And so there is a little bit of a process that we will walk through, that we will have our clients walk through. I think for the everyday person that doesn't have the resources to hire the best to walk them through this process, I think foam rolling and active stretching for the hip flexors, for the quads, there's lots of information on the internet out there that you can find. But just probably the biggest thing is just rolling and active stretching your hip flexors before you start to try some of these stability moves, like the outer thigh raise specifically, will really help increase your chances of success.
Okay.
Great question. Okay, so the next part of that, of joint problems, is structural issues. So structural issues are things that you can see on an MRI. It is findings that you can get on an X-ray, on an MRI, on a CT scan, and there you'll get a report with big words, right? And the dangerous thing about these findings is that all of these findings aren't created equal. Some findings have high correlations to pain, and some findings have low correlations to pain. And what that means is that some findings, like arthritis, like degenerative disc disease, they don't create pain. There's just scientific evidence stacked a mile high that you can have these conditions present on your MRIs and on your X-rays and have zero pain whatsoever. And then there are high correlation conditions and findings that just have extraordinarily high chances of creating pain, really severe spinal stenosis, really big disc bulges with nerve impingement, bone spurring with nerve impingement, these types of things that if you find them on an MRI, it's just best to get them cleaned up surgically at that point, because there's just such a high correlation to pain that as long as those conditions are present, you're going to be in pain. The hard part is in distinguishing between, is this finding on my MRI or X-ray important or not? That's the hard part. And there's some easy ones that we can list, like the conditions that just don't cause pain. Degenerative disc disease, spinal arthritis, small bone spurs, small disc bulges. These are just normal findings on MRIs that anyone over 45 years old is going to have, and they're just not a cause for concern. Then you have high correlation findings that are likely causing a big percentage of your pain, such as really severe stenosis, really severe bone spurring, really severe disc bulges, really severe instabilities like spondylolisthesis. Again, Google is your friend with these things. You can get pictures and images of all these conditions to understand it better. But the big takeaway here is that not all findings on MRIs and X-rays cause pain. And so you really need to either do your research or find a world-renowned expert surgeon who can tell you what is important and what's not important on those MRI findings.
Absolutely. And I think you'd know better than me. On MRI, when you get the report, does it list in category what should be the worst? Where's my pain? Or is it
Man.
just...
That would be nice if there's any doctors listening, anyone responsible for writing those reports. That would be a really nice feature of MRI reporting. Unfortunately, no. So it's just listed by joint segment. It's okay. My lumbar spine has this big long list of problems, and it just looks daunting. It looks scary. There are words that you've never heard before that you can't even pronounce. And there's no distinguishing grading as to what's important and what's not important. And I think probably the scarier part is that the interpretation of what is important and not important then comes from a doctor who may or may not be well versed in the research. And so we have 4 best practices when it comes to navigating structural issues. And the first best practice is go to a world-class surgeon. So because you're reliant upon the opinion, or you're reliant upon this person who is flawed in all the ways that humans are flawed, right? Who to interpret the findings of this scan, right? You're also at the mercy of the quality of the imaging device that took the picture. And so I was in really severe chronic pain for 13 years, and I had got lots of medical opinions, small town medical opinions, and when I got to the UCSF Pain Center, they looked at my images and said, we can't even use these. These are so low quality, we can't see anything from them. And so I was getting medical advice based on images that were so low quality, they couldn't see anything with them. Wow. And so at the UCSF Spine Center, this is a plug for UCSF, not getting paid for it, although if they want to, please feel free to send me a check. They took me and they went, we need better images. Go down to our MRI, get the images, come back, and we'll see you in an hour. We took high quality images. The surgeon looked at it at that time, and we made a plan. And it wasn't, my structural issues weren't the only thing causing my pain, but I couldn't have gotten out of pain without that high quality scan and without that high quality medical advice.
Absolutely.
Go to a world-class surgeon. That's best practice number 1. Let's keep jamming. So best practice number 2, trust their advice on structural matters and don't be afraid of surgery. I think probably deservedly so. People are afraid of back surgeries. They're afraid of surgeries in general. And sure, I mean, I get that. For a long time, back surgeries were sort of known to have like a 50% chance of success. Well, that may be true. I don't think that's actually the statistic, but that may be true when you take the vast swath of everybody in the world getting back surgeries. That's not the right statistic to look at. You need to go to a world-class surgeon and look at their success rate, look at their outcomes, because the difference between a world-class surgeon and everybody else is that they will be much more picky about who they do surgery on. So they're not just going to be a mill just churning and burning surgeries. They're going to slow down. They're going to take the time to get a high quality MRI, and they're really going to determine, does this person need back surgery? Are we going to get a good outcome? Or do they really need to just go try something else? Do they need conservative therapies? And world-class surgeons, they keep track of their outcomes. All the other surgeons, they'll just do the surgery. They may do a follow-up at 6 weeks, and then you never hear from them again. You never tell them how they're doing. And so that surgeon never actually knows, did I get a good outcome from that? World-class surgeons are tracking things like that. And so you can ask them, what type of outcomes do you get? What type of outcome can I expect from this? And if they can't speak with a high degree of certainty, then you're just not in the right place.
Yeah, absolutely. I did not know they tracked that.
Yes, the best ones do.
Best one.
A lot of practices don't, and that's terrifying.
Yeah.
I mean, they'll cut into you and talk to you one more time at the 6-week mark and then give you a pat on the back on the way out and take your $150,000. Like, that's a terrifying prospect. And so there is a vast difference in quality between world class and the average when it comes to surgeons. And so just go to the world class. It's worth it to make the drive, to make the flight, go to the best. And that'll be different surgery by surgery and joint by joint. So we can't give like a really detailed list. I know we send our clients, we're here in California, we send our clients to the UCSF Spine Center, and they are world class. The third best practice, do your prehab and rehab afterwards to fix all the joint instability problems that likely caused the structural issues in the first place. So don't just get the surgery and then expect all your problems to be gone. That structural issue was one of 20 problems. You get the surgery, you cleaned up one. You still have 19 to go. Yeah. You're not done yet. So do the prehab, get the surgery, do the rehab afterwards, fix the rest of the problems, and you will increase your likelihood of success extraordinarily. Fourth best practice when it comes to navigating structural issues. If you want to be better informed on structural issues and when they do and don't need surgery, read David Hanscom's book, Do You Really Need Spine Surgery? Again, doing a little bit of a plug here. We are not getting paid for that. This is an extraordinary resource that we give out to a lot of our clients. David Hanscom is a world-class surgeon, and he creates a method and a grid for teaching people, do you really need surgery or not? Because he lays out the stats and shows how poor the outcomes on back surgeries really are. But he goes deeper than that and doesn't just throw the baby out with the bathwater. He dives deep into the data and goes, okay, what surgeries had good outcomes? What conditions were present where bad outcomes were had, and he created a grid for evaluation as to when people should and should not get back surgery. And so that's a great resource for people. We will put a link to that book in the show notes.
Perfect.
Okay, the second part of the equation, stress problems, inflammation problems. Eliminate inflammatory foods. Ultra-processed foods. So grains, dairy, alcohol, ultra-processed foods as a category. If you can't make it in your kitchen, it's an ultra-processed food. If it is something that needs to be made in a commercial kitchen because there's so much processing and additives, that's an ultra-processed food. And eat a wide variety of minimally processed foods. And if you've done all that and you still have a persistent inflammatory problem, get help from an expert. And you can't get out of pain if you don't bring persistent and chronic inflammation levels down.
Definitely.
The second part of inflammation problems is you need to be getting 3 30-minute low-intensity aerobic training sessions in per week. And the reason for this is multidimensional, but the first one is moving lymphatic fluid. So your lymph fluid is the garbage system of the body. It's just clearing out all those inflammatory mediators out of your joints. And when you're in pain, you move less. And when you move less, you don't move lymph fluid. And when you don't move lymph fluid, you leave inflammation in the joints, and then you hurt worse, and that becomes a downward spiral. So getting those low intensity aerobic sessions in 30-minute sessions per week is critical to moving lymphatic fluid. And that can be really easy. That can be a walk, that can be a recumbent bike, that can be on a rebounder. It's anything that's not going to make your pain worse. You shouldn't be pushing through pain in order to get your aerobic sessions in.
Yeah. So what would you recommend for someone that is in pain but still wants to work on the lymphatic system? But long walks for 30 minutes is
not achievable at this point. Yeah. So sometime when people are working with us, a lot of times we will wait to institute the aerobic sessions into their program because we have to get the instability, the pelvis and the core instability problems figured out first. So once we get those off the table and fixed, then we add in the aerobic sessions and we start clearing out those inflammatory mediators. And so it can really start to be like this big hockey stick curve where we fix a couple problems. That gives us more access to more treatments to clear out more problems, and we can really start to make some fast progress. And so we'll talk next, we'll actually talk about an optimal treatment order. But if you can't do those aerobic sessions because of pain, then just wait, fix the instability problems, then go back and try the aerobic sessions, and you will likely be able to do them at that point.
okay.
Nervous system problems. So get strong and aerobically fit to unwind memorized pain patterns and regulate your nervous system. So pain is a nervous system response, and pain patterns can be memorized. This isn't perfectly scientifically accurate, but it's fine for an analogy. Those pain patterns can get memorized in your peripheral nervous system and in your brain. And so you can get these memorized signals that just get stuck in the on position. So even when an original problem that created someone's pain in the first place is gone, it was fixed or it healed, the pain signal can get stuck in the on position, despite that original problem being gone. And so getting strong and aerobically fit helps to unwind those memorized pain patterns and regulate the nervous system.
Okay. You mentioned in the peripheral nervous system.
Yep.
Can you just define that a little bit?
Yeah, so the peripheral nervous system is the nervous system that comes away from the spinal cord. So your central nervous system is your brain and your spinal cord. Your peripheral nervous system is everything that comes away from your spinal cord, going out down your arms, out down your legs. It is the sensors of the body. So when I feel touch or when I feel pain out in my finger, my peripheral nervous system, my nerves, are sending that signal up to my brain to be interpreted. And those signals can get memorized or stuck in the on position in both parts of the nervous system because they are distinct.
Okay.
The last part of the nervous system problems is you have to treat anxiety, depression, and sleep disturbances. These act as amplifiers for pain problems. So the way this often looks is people will have some pelvic instability, they'll have some core instability, that'll start to create some structural issues in their spine. They're eating the standard American diet, and so they're getting some inflammatory problems, and then you start to get increased levels of anxiety, increased levels of depression. You can't sleep as well because you're in pain. And that anxiety, depression, and sleep disturbance set of problems just acts as a multiplier. It just acts as an amplifier of those pain signals. And so what would otherwise be a 4 out of 10, which is pretty livable, becomes a 6 or a 7 out of 10 because you have this nervous system amplifier of not getting enough sleep, having stress, anxiety, and depression. And so the big takeaway there is if you got to work those problems. There's lots of resources out there, but you got to work those problems, and And if you can't fix them alone, work with a professional, work with a counselor, and get those problems resolved in order to get out of pain.
Can those problems be so big that they're affecting everything in terms of, obviously no one's perfect, but stability's decent? But that issue of the nervous...
Can it be a prime cause?
The main
it
issue.
absolutely can. So you see, this is some fun research, not fun, but it's really interesting. So the rate of chronic pain in people with diagnosed PTSD is 93%.
Wow.
And the PTSD didn't come second; it came first.
Yeah.
So people got the PTSD, and then the chronic pain came later with that. Same thing. Sexual assault. The rate of people with chronic pain who were victims of sexual assault is extraordinarily high, and so these anxiety, depression, and sleep disturbance problems can absolutely be primary pain generators.
Okay, thanks for explaining that.
Yeah, good question. Next, let's talk optimal treatment order. So what things do you fix first? What things do you fix second? What are first order problems versus second order problems? So the big driver of that is this problem chronic or acute? And so chronic problems have been around for longer than 6 weeks. And there is no clear cause for the pain. It's one of those non-specific low back pain cases. And the alternative to that is acute pain, something that that is a pain that has been around for less than 6 weeks, and there is a very clear known cause or event for the pain. You have to think about and treat those differently, as you well know. So chronic. First order treatments for chronic pain. And chronic pain can be intermittent. It can come and go, right? It doesn't mean that it's constant and persistent. Chronic pain can be just this recurring thing that happens 4 times a year or 3 times a year. That is also chronic pain. So first order treatments for chronic pain. You want to calm the inflammatory and the nervous system. So deal with those ultra processed foods, get the low intensity aerobic exercise, and treat and deal with the anxiety, the depression, and the sleep disturbances. Next, correct pelvic and core instability. So deal with that glute medius, that outer thigh raise instability, deal with that hip flexor and abs instability, deal with that posterior chain instability. Then, if needed, if you do all those, you will likely fix that problem. But if needed, then go to second order treatments for chronic pain, which are an MRI, a world-class surgeon, a naturopathic MD for entrenched inflammatory and nervous system problems, a counselor for anxiety, depression, and sleep disturbances. We good there?
Absolutely.
Acute. If your pain is acute, lasting less than 6 weeks with a clear known cause or event. First order treatments are physical therapy or an MRI to clear specific structural causes. And ensure you are getting the best advice if you are going to do that. We talked about this already. The biggest thing that slows down people's pain journeys is just getting bad advice.
Yeah.
And so go to a world-class doctor, get their opinion on if it's acute, and just to clear any possible specific low back pain causes.
And acute, do you want to explain how that runs into chronic if not fixed?
Yeah, so acute pain, if not dealt with properly, will morph into chronic pain. And even when the specific injury resolves itself, you can be left with this lingering chronic problem through all sorts of possible causes. That nervous system memorizes that pain pattern. You get this inflammatory response that's persistent in the area. You had some biomechanical problems that may have even been the root of that acute issue, that if undealt with just create this persistent chronic problem. And so, yes, that is a great point. Acute pain will often morph into chronic pain if not dealt with properly.
Okay.
So second order treatments for acute pain are correcting pelvic and core instability. So that glute medius, that hip flexors and abs, that posterior chain, the muscles on the back side of the body, weakness through those muscles. Then calming inflammatory and nervous system stressors, getting rid of ultra processed foods, getting your aerobic sessions in, and dealing with stress, anxiety, depression, and sleep disturbances. That is the optimal treatment orders.
Perfect. Sometimes you have clients that come in and say, I have chronic pain. My family had chronic pain. It was a chain of events through the family. Is this genetics? Can you explain a little bit on that?
Yeah. So genetic heritability for low back pain is currently estimated at 30 to 40%. And so there is a genetic component to low back pain. But it's not, it has to be dissected and understood a bit. The genetic component to low back pain is in the materials. And so there is a gene that dictates how dense and thick your the wall of your disc is. And so the discs between your spine, the little pillows that allow for movement, they have a wall, an annular wall, and there are genes that dictate how thick and dense those are. Some genes will signal a thinner disc wall, and therefore you'll be more prone to degenerative disc disease or bulging discs. Rate of bone growth relative to loading patterns. And so some people will have pelvic instability, core instability, and they'll just get these big bone spurs, these big spinal stenosis that closes in around their spinal cord, because there is a gene that activates aggressive bone growth. And then other people have a less aggressive bone growth to loading patterns. And so there is a genetic component to how aggressively is your body going to respond to these improper loading patterns. And then the last, just another example, it's not the last one, but is heightened nervous systems. So the anxiety, depression, and heightened pain responses can have a genetic component to it. And but with all genetic traits, these genes live in the environments that we place them in. And so we can have a predisposition toward a certain genetic problem, but that doesn't mean that they have to express themselves. We can create an environment that is healthy and optimal, where our pelvis is stable, where our core is stable, where we're not eating ultra-processed foods and we have low levels of anxiety, depression, and we're getting good sleep, and we're doing aerobic work, and we're doing strength training, and really create an optimal environment so that we don't have to have pain, right? And I think that's the message that that we want to end this with, is that you don't have to be in pain. Answers exist, and there is a way out of pain.
Absolutely. I think that was great.
Cool. Awesome. Well, I think we are good. I think that sums up our masterclass in how to fix low back pain. And thanks for coming and doing this with me. I appreciate it.
Thanks for having me. It's a lot of fun.
Thank you for watching the Joint Pain Podcast. I'm Matthew Lister, and if you want help walking through your chronic pain journey, you can find more information at experiencealign.com.